Sir.
Okay. Today we are going to discuss about the OSCE radiology in second part. So, Dr. Priya Alice, are you online? Hello.
Hello, good evening, sir.
You are online?
Yes, sir.
So, here I am going to ask very common radiology slides. So, with some questions, what are the expected questions? The students who are in the online also, they can answer by typing, not in the verbal. So, we appreciate your answers in the chat box, not in the verbal. And Dr. Priya Alice, you have to, I will ask some few questions about this slide. You have to identify why you tell like this, why this is your diagnosis, and I will related questions I will ask. Okay, let's start.
Okay, sir.
So this is the first question, first slide. Can you describe this?
Sir, this is a X-ray of skull lateral view showing multiple lytic lesions, sir. Consistent with punched out lesions, sir. Probably a case of multiple myeloma, sir.
Multiple myeloma. Okay, very good. So in the multiple diagnosis, these things, what are the, do you know about skeletal survey?
Yes, sir. It is a series of X-rays taken now for mainly for axial skeleton, sir, to assess bone lesions.
Not only axial skeleton, you have to take all starting from the skull, all axial skeletons, appendicular skeletons, thorax, everything from the toe, all X-rays, epilateral views you have to analyze. Now the MRI PET CT has replaced the total skeletal survey. Do you know how it is Kraft criteria?
Yes, sir. Kraft criteria is for elevated calcium or renal insufficiency, anemia, and bone lesions, sir.
So there is an extended Kraft criteria known as a slim Kraft. Okay, have you an idea?
Yes, sir. SLIM stands for more than or equal to 60% clonal plasma cells in bone marrow, sir. And LI is light chain ratio, sir. If it is more than 100 milligram per liter, or M stands for more than one focal lesion on MRI, more than 5 mm in size, sir.
Okay, so mostly like a skeletal, these things, they will related questions asked. Second question. So here, can you tell about this slide?
Sir, in this slide, I can see axial view of first it depicts axial view of CE-MRI T1 sequencer, and B is axial view of CE-MRI T2 sequence, and C depicts CE-MRI flare sequencer.
Not C MRI, MRI, plain MRI. C meaning contrast enhancement. There is no contrast anything. No C.
Okay.
It is a axial view of such a axial section of MRI showing T1, T2, and T2 flare. Okay. How you will identify? Easy, you told like that. How you will identify?
Sir, in T1 sequence, gray matter appears hypointense and white matter appears hyperintense, and the fluid appears hypointense. Whereas in T2 sequence, gray matter appears hypointense, gray matter appears hyperintense, whereas white matter appears hypointense, and the fluid appears hyperintense. Whereas in flare, gray matter appears hypointense and hyperintense, and gray matter appears hyperintense, and white matter appears hypointense, and fluid appears hypointense with ventricular ooze will be there, sir.
So very easy way to identify the T1, T2, and T2 flare is there is a just see the ventricles. If ventricular is black, then think that it is a T1 plain. If ventricles are white by hyperintense, it is a T2. You can see the edges. This is called edges. That is called oozing. If there is a ventricular wall oozing is this, it is a T2 flare. Okay. Here is the swam lesion is there. Can you explain?
Sir, in T1 post contrast axial view is seen, sir, showing irregular mass, irregular mass seen, sir, which is hyperintense peripherally and with central hypointense areas, sir, mostly due to necrotic component. Whereas in T2 sequence, I can see solid cystic component with peripheral edema, sir, perilesional edema. And in flare, I can see. Sir, in flare sequence, I can see there is a pathological edema surrounding the mass lesion, sir.
Okay, so it is a looks like a high-grade glioma. It is a contrast enhancement lesion, left parieto-occipital area with a cystic lesion or hyperintense lesion with hypointensities in this in center. So mostly it describes a necrotic area. In T2, you will see the all fluid areas like pathological fluid as well as normal fluid looks bright, but pathological fluid is bright in the flare. Mostly takes to high-grade glioma. Can you depict what is this picture saying?
This is a MR spectroscopy, sir, showing two graphs. The first graph showing it appears normal, sir, because the choline creatinine ratio is normal and NA peak, NA is peak is there, sir. Whereas in second graph there is a choline peak is there and NA graph is down is less, sir. And there is lipid lactate peak also is there, sir.
So it is a MRS picture. MRS is magnetic resonance spectroscopy. It is the measuring the chemical nature of the tumor. Okay, so above the tumor, above the graph, the upper graph is showing the normal MRS. Lower is the abnormal MRS of the lesion. Where in abnormal MRS there is a choline peak is there. So choline citrate ratio also increased, and there is a decreasing and favoring the high grade glioma. Okay.
Okay.
Now explain this one.
So this is an axial view of T1 sequence of CMRA brain cell showing well-defined lesion in right frontoparietal region, showing heterogeneous intensities, heterogeneous lesions, sir, with dural enhancement I have seen, sir, consistent with the dural time signs, sir.
So it is mostly depicting high dural tail sign and left frontoparietal meningioma. What are other signs you know?
Sir, in meningioma, we'll see CSF cleft signs here. On angiogram, we can see spoke wheel sign or sunburst signs here.
So there are 7-8 signs are there, mainly dural tail sign, CSF cleft sign, mother-in-law sign, sunburst sign, and spoke wheel sign. Okay.
Oops.
This arrows depict what is the image you can say? You can.
Sir, this image is depicting the flow of CSF pathway, sir.
So can you describe the CSF pathway in these arrows?
Yes, sir. From lateral ventricles, it drains into the third ventricle through foramen of Monroe, sir. From third ventricle to fourth ventricle, it will drain through aqueduct of Sylvius, and in fourth ventricle, it is connected to two more apertures, which is foramen of Lashka, lateral aperture, and foramen of Magende, medial aperture, which further drains into central canal, sir, and further into subarachnoid space, sir.
Okay, so and can you name some tumors with that travel CSF spread?
Yes, sir. Pineoblastoma, ependymoma, or medulloblastoma.
Mostly you have to tell medulloblastoma first, then ependymoblastoma, anaplastic ependymoma, then germ cell tumors. Okay, okay. What is the structure here you are finding?
Hippocampus, sir.
What is the importance of this?
It is important for memory, sir, to convert short-term memory to long-term memory, sir.
So why it is so important and how you will give the constraints?
Sir, its importance is during when we are planning for whole brain RT, sir, we need to have constraints. Mean dose of the hippocampus should not cross more than 10 gray, sir, and maximum dose to hippocampus should be within 16 gray, and the volume receiving 17 gray should not exceed 2%, sir.
Okay. Can you describe this?
Sir, this is CMRA of showing axial, coronal, and sagittal views, sir, in posterior fossa lesion in left CP angle, sir. Lesion is hyper intense in T1 weighted T1 post contrast image, sir.
So mostly it looks like a medulloblastoma, pediatric brain. So can you differential diagnosis 3 tumors happens in the pediatric area in the posterior fossa?
Ependymoma, pilocytic astrocytoma, sir, or atypical rhabdoid tumor also, sir.
ATRT, and apart from that, you can go for the third ventricular ependymoma, pilocytic astrocytoma. Sorry, fourth ventricular ependymoma, pediatric ependymoma, pilocytic astrocytoma, and medulloblastoma.
Okay.
Describe this slide.
Sir, this is a CT scan, CT scan of axial view showing nasopharyngeal region, sir.
Can you depict the arrows?
Yes, sir. Here A is depicting medial pterygoid plate, sir. B is showing lateral pterygoid plate. C depicts tuberous tuberous, sir, whereas D depicts clivus, sir, and the red arrow is showing Rosenmuller, sir.
Rosenmuller fossa. Why it is so important, Rosenmuller fossa?
Sir, that is the most common site for nasopharyngeal carcinoma, sir.
Okay. Explain.
So this is image is showing both the axial views of CT and MRA also, sir. It is showing cochlea, sir. Bilateral cochlea.
Bilateral cochlea. There are two sequences. One is the CT, another is MR sequence. MRA, which sequence you know it is?
This is a Fiesta sequence, sir.
Very good. In Fiesta sequence, which is best to see the cranial nerves. Okay. Which cranial nerves you see here?
7th and 8th cranial nerves, sir.
Anteriorly 7th, posteriorly?
Posteriorly 8th cranial nerves.
8th. Somebody did contour, it is okay?
Yes, sir.
Shall we contour the semicircular canal?
No, sir. We should take the only whatever they have contoured in this slice, no, sir. That should be contoured, sir. We should not take semicircular canals, sir.
Very good. What is the mean dose you know in head and neck practice?
Mean dose should not cross more than 45 days, sir.
Okay. Okay. Tell me this one.
Sir, this image depicts white reflex, sir. Leukocoria, sir.
Leukocoria. What is this?
Mostly seen in retinoblastoma, sir.
Retinoblastoma. White pupillary reflex, white pupillary. Okay. What is this?
Sir, this is CT scan of axial skeleton in sagittal view, sir.
Can you count the what is the anything is there? Any abnormality?
Yes, sir. Few lytic lesions were there, sir. Seen in
which vertebra involved? Can you count?
Yes, sir. From D12 vertebrae and D7 vertebrae, I can see lytic lesions, sir. And D12 vertebrae, there is compression also, sir.
So what you will do? What is the commonest malignancies? It is go for the metastasis like this.
Sir, breast malignancy or multiple myeloma also, sir, or lung malignancy, sir.
Okay. Breast, lung, Okay. And what are the things? It is whether you will go for the surgery or radiation.
First, we have to assess with the SIN score, sir.
What is SIN score?
It contains 6 components, sir, based on the anatomical location and patient mechanical pain or involvement, compression of the vertebrae and the posterior lateral involvement of the spinal canal, spine, and type of lesion and spinal alignment also, sir. It have a score range from 0 to 18, sir. Anything beyond the 13 should be taken for emergency decompression surgery, sir.
Okay. Can you tell about this? What is this slide depicting?
Sir, this slide shows Bilski score, sir. Used for epidural spinal disease causing spinal cord compression, sir. Here we can see it have a grade 0 to grade 3, sir. Grade 0 is when the disease is only confined to the vertebrae and not crossing epidural, sir. Whereas grade 1A is where the disease is touching the epidural, sir. Whereas grade 1B is it is in contact with the epidural and and also causing a deformation on a thecal sac, sir. Whereas grade 1C, it is causing deformation on thecal sac and also in contact with spinal cord, sir. Whereas in grade 2, it is in contact with spinal cord and also causing a compression on spinal cord, sir. But here you can see clear as CSF, sir. Whereas in grade 3, there is complete compression of the spinal cord and the clear CSF cannot be seen, sir.
Okay. Can you explain this one?
Sir, this image shows X-ray of pelvis, sir. X-ray of left hip joint, sir. Mostly there is a hypoechoic.
It is not a hip joint. It is a upper part of the femur around the lesser trochanter. Okay.
Okay, sir. Here I can see a hypoechoic lesion around subtrochanteric lesion region, sir. And
so it is a osteolytic lesion. Most probably, if in a cancer patient, most probably it is by a metastatic lesion. Okay. Okay. So how will you go? Either go for surgery or radiation?
Again, we have to see for middle score, sir, in such patients, sir. Based on the same patient's symptoms, sir, and whether the upper limb site of anatomical region also, sir, and cortical involvement and type of lesion also, sir.
So what beyond which middle score you have to go for the surgery?
More than 8, patient should go for surgical intervention, sir.
Okay. Decide this one. Explain this one.
Sir, this is CECT axial view of CECT face head. Sorry, sir. This is axial view of MRI. T1 contrast MRI, sir. Here I can see hyperintensity along the right lateral border of the tongue. It is crossing the midline also, sir, and it is extending posteriorly also. Okay.
So, if some person went for surgery, in which indication you will give the radiation?
Sir, if the post-operative radiotherapy indications will be in the T3 or T4 stage disease, T3 or T4 stage disease, or any LVA with LVA positive or PNA positive, or more than or equal to 2 lymph nodes, sir, or close margins, that is less than 5 mm, which are microscopically negative, sir.
In which conditions you will go for chemotherapy aiding?
Sir, CTRT indications are mainly two indications, sir. Extranodal extension or positive margins, sir. Okay.
Describe this lesion.
Sir, this is a coronal view of CT face, CT scan of head, sir. with the puffer cheek technique, sir.
You should not tell head, it is a oral cavity.
Okay, sir.
What is the advantage of puffed cheek?
Sir, puff cheek advantage is when in small lesions which are in vestibule of the mouth, it is easy to assess, sir. We can see whether the lesion is confined to the buccal mucosa alone or if it is confined to sulcus or alveolus, sir. Extension of the disease with
Upper GBS involvement, lower GBS involvement, we can see easily. If small lesions are there, whether it is involved originated from the buccal mucosa or okay. CT scan showing there is a big node. Can you tell me what is this node depicts?
Sir, here the node we can see necrotic necrotic node, sir, which is infiltrating left sternocleidomastoid muscle. Mostly, it is depicting extranodal extension, sir.
Okay, can you name some signs in clinically?
Sir,
How can you tell that the patient having extranodal extension?
clinically, hard node.
Hard and fixed node, and fixed to the skin, underlying skin is hot.
Okay, no problem. What are the radiological signs?
Sir, radiological signs with the matted nodes or invasion of the adjacent structures or loss of capsular.
So clinically, if it is a more than 3 centimeter node, maybe skin infiltration, matted node, underlying subtissue fixation, these are the clinical. Radiologically, muscle infiltration, vascular infiltration, necrotic nodes, and there is a 3 signs called Segi sign, flare sign, another sign I forgot. So these are the MRI findings where you can tell as a extranodal extension is there. Okay. Okay. Wow. Can you depict the arrows? Which structure?
Sir, in image A, black arrow is depicting hyoid bone, sir.
Okay.
And white arrows are depicting valliculus, sir.
Okay.
And white arrowhead is depicting epiglottis. And B image, white arrows are depicting aryepiglottic folds, sir. And white arrowheads are depicting pyriform sinus. Whereas in C image, the white arrow is depicting thyroid cartilage, sir. And black arrowheads are depicting aryepiglottic folds, sir. And black arrow is depicting erythroids, sir.
So remember, always the examiner will ask, do a DL-scopy or ideal-scopy or CT scan image, they will ask. So before going to exam, just practice DL-scopy and ideal-scopy. Okay. What is this?
Sir, this is a
Apple core sign.
Hello.
Okay. I am requesting you, other than Dr. Priya Alice, I appreciate if you answer in the chat box rather than verbal, because there will be background noise. Okay. Thank you very much. So Priya Alice, can you explain?
Yes, sir.
What is this image?
Sir, this is a barium swallow image, sir.
Barium.
Showing rat tail appearance, often seen in malignancy.
Okay, so it is called barium swallow, red tail appearance, mostly maybe malignant in nature. And what any other barium barium radiology, you know, other names? So there is called barium enema, barium follow through. Okay.
Barium meal.
So these are the now barium nobody is doing, and okay, barium meal. Can you tell this thing?
Sir, this is barium study of oropharynx.
Barium swallow.
Barium swallow.
This
Yes.
is barium swallow. Earlier done.
Okay, sir.
Okay. What is the C depicts and E? Sorry, C and F.
Sir, here C depicts vallicular, sir, whereas F depicts piriform sinus, sir.
So these are the two bulgings you have to identify properly. If there is a filling defect, we can tell that is the we can suspect malignancy. Okay, describe this.
Sir, this is the chest X-ray PA view, sir, showing multiple hyperopic lesions.
Never tell in hyperechoic in the X-ray. Okay.
Okay.
Echoic is in ultrasound.
Opaque, sir.
Opaque.
Hyperopic lesions of variable sizes seen on both the lungs, showing cannonball appearance, consistent with the cannonball appearance, mostly lung metastasis.
Okay, where is the common you will find out?
Commonly seen in renal malignancy, breast malignancy, or choriocarcinoma, sir, or testicular malignancy also, sir.
Germ cell
tumors.
Okay. Describe this one. Describe this one.
Sir, this image is showing HRCTV thorax, showing a speculated lesions in right lung, sir. Hyper dense lesions, sir, with irregular margins and with irregular and speculated margins in the peripheral, sir.
So mostly speculated margins. Okay.
Okay, sir.
They describe this.
Sir, this is a mammogram showing of two views, sir. First is mediolateral oblique and second is cranial view, sir.
Okay. Okay. So why mammogram to be done?
Sir, mammogram need to be done to assess the prior surgery, sir, to know whether any calcifications are there or to know
microcalcifications. Okay.
Microcalcifications or manipulations or architectural distortion or any, we can even see axillary lymph nodes also, sir, sometimes. And
so architectural distortion and the mass microcalcification, axillary opacification may sometimes you note is there, but when you are reading an MRI, a mammogram, you have to be with a magnifying glass. Okay. And what is the how to define the lesions? Any criteria? Hello. Hello, Priyalis.
Yes. Hello, sir. Sir, am I audible, sir?
Yeah. Please go ahead.
Sir, here we'll use a BIRADS reporting system, sir.
What is BIRADS?
BIRADS is a breast imaging reporting and data system, sir, which ranges from 0 to 6, whereas 0 stands for negative, no evidence of disease, whereas 1 is inconsistent.
So what is your fifth? BIRADS 5. What is BIRADS 5?
BIRADS 5 is highly suggestive of malignancy, sir. More than 95% risk of disease.
Okay.
Biopsy is a mandatory, sir.
Okay, explain this one.
Sir, this is axial view of CT pelvis, showing the arrow is depicting a mesorectum, sir. Can
you boundary of the mesorectomy can tell?
Yes, sir. Sir, mesorectum superior boundaries where the inferior mesenteric artery divides into sigmoid, it gives branches into sigmoid artery and superior rectal artery, sir.
Inferior margin?
Inferior margin is where ischiorrectal level inside the level of levator ani, sir.
Okay. So define this lesion.
Sir, here there are axial view of CCT pelvis
Mhm.
showing there is hyper dense lesion in cervix and uterine uterus also, sir. And there is a heterogeneous enhancement is there, sir. And the lesion seems involving parametrium also, sir. And there is in fourth image we can see one pelvic lymph node also, sir.
Left side. Okay.
Left side, sir.
Identify the ABCD.
Sir, this is MRI pelvis. So A is depicting transitional zone of prostate, sir, whereas B is depicting peripheral zone of prostate. That area corresponds to neurovascular bundle, sir.
Mhm.
Whereas D is depicting a seminal vesicle, sir.
So can you tell me if a lesion in the prostate, how it looks like a hypointense or hyperintense?
In T2 weighted imaging, it will look hypointense, sir.
In the cervix, it is a
Hyperintense, sir.
very good. Can you depict this one?
Sir, this is CEC axial view of CECT abdomen, sir, showing multiple hypodense lesions all over the liver, sir, consistent with the liver metastasis, sir.
Can you define the common malignancies?
Common malignancies would be colorectal and breast
Okay.
or cervix also.
What is this one?
Sir, this is triple phase CECT abdomen, sir.
What is triple phase?
Triple phase which have both have arterial, portal venous or equilibrium phase, sir. Delayed.
Delayed phase. What is that?
At post contrast based on that post contrast time we will take three images during three times.
Mm-hmm.
In arterial will take the image after 22 to within 20 to 30 seconds post contrast, whereas in portal venous we will take in the next 62 sorry from the post contrast 60 to 70 seconds will take, sir, whereas delayed or equilibrium phase will be taken 3 to 5 minutes post contrast injection, sir.
Usually 10 to 20 second is arterial phase.
Okay, sir.
20 to 30 it is the venous phase, and that is the beyond that is the delayed phase.
Okay.
So there is a lesion here. Can you describe?
Yes, sir. There is a hyperdense lesion with hypoechoic in arterial phase. There is hyperdense lesion, sir, with hypodense central area. Washout is there in post venous in portal venous imaging. I cannot appreciate, sir, but in equilibrium image, there is.
It is washout, and delayed phase it is a capsule. So it is a pedo capsule. So mostly it is a HCC.
Okay.
What is the treatment options?
Sir, surgical.
So as a radiation oncologist, you have to tell SBRT, radio frequency ablation, and surgery. Okay. Okay. So there are 4 images here. Okay. One images. What is the A showing? One sign is there.
It is showing sunburst appearance, sir.
Mostly seen in
osteosarcoma, sir.
B
is showing Codman's triangle, sir.
What is Codman's triangle?
Codman's triangle, when there is an aggressive growing tumor, it will not allow the periosteum. It will push the periosteum away from the cortex, sir, forming a triangular area, sir.
So elevated periosteum.
Elevated area is periosteum, whereas the hypo-opaque lesion seen is a tumor, sir.
Third picture is?
Third picture showing multilamellar appearance, onion peel appearance.
Where you will see?
Ewing sarcoma, sir.
What is the onion peel appearance?
In slow growing tumors, there will be intermittent periosteal reactions. So there will be intermittent formation of periosteum, concentric formation of periosteum along the bones. That will give rise to onion peel appearance.
Okay. Then D.
D showing soap bubble appearance. Showing
Okay.
multiple hypopachic lesions, lobulated lesions in the.
So mostly you can see find in germ cell, giant cell tumors. Okay.
Okay.
What is this?
So this is whole body PET CT scan, sir.
In which conditions you do mostly?
In lymphoma cases, sir.
Lymphoma, any mostly lung cancers, breast cancer. Okay. So if you suppose if you are thinking of lymphoma, you told first after the completion of given chemotherapy, total response. How will you score the response?
Sir, we will use dually score, sir, which is a 5-point score system, which will assess the based on the metabolic activity, sir.
So which is a good response, which is a bad response?
Good response is 1 to 3 dually score, sir, whereas 4 and 5 are considered poor response, sir.
Okay. So how PET CT is formed? Have you ever visited your PET CT department?
Yes, sir.
Can you explain slightly procedure? No?
I can't.
Okay. So PET CT, you have to do dual PET CT, PET CT is a PET and CT dual scanner is there. They will give what is the tracer they give?
18 FTG, sir.
Any other PET scans you know?
Yes.
Other than FTG PET?
Dopa PET is there, sir. PSMA PET is there. Methionine PET and
What is the brain specific PETs you know?
Dopa PET, sir, and methionine PET, sir.
Okay.
Dota PET also.
Dota PET is for meningioma, not brain specific.
Oh.
So what is this?
Bone scan, sir.
Okay. What is a super scan?
Super scan. Bone scan of.
So when you do the bone scan, usually excreted with your kidney. But if you see up first two pictures, you can delineate the kidney. But in the last picture, you're not able to delineate the kidney. Okay, so the tracers are taken by the extensive metastasis. You cannot see the kidney. So that is called a super scan. Okay, so what is the tracer they give?
Technetium 99 MDP, sir.
And what is the dose you know? Activity?
I don't know, sir.
20 milligram, na? Just please check once, okay?
Okay, sir.
What is this?
Thyroid scan, sir.
Okay. So radioiodine scan, not thyroid scan. It is a
Radioiodine sensitography.
where you will do actually?
In evaluation of thyroid nodules or any evaluation of thyroid malignancies, sir.
So pre-op or post-op?
Pre-op only, sir.
Pre-op.
Post-op.
It should be done on post-op. Pre-op.
Yes. Malignancy. Thyroid nodule pre-op.
Okay. So dear students, we have completed the radiology OSCE, most common CT, MRI and in investigations. It does not mean that they will confine to this. They have many MRI, CTs may be there in their examination centers. But these are the minimum things you have to understand and you have to know. And we will upload with answers within few minutes to the Mpro group or short notes group or OSCE group. Please go through it. And any comments from the students? Now you can talk. How you felt it, how it was going on. Tomorrow another session is there, coming 7 days full sessions will be there. It is boring or it is okay, exciting? What do you feel?
It is very kind of you to be so much concerned about our learning, sir. Thank you so much, sir. Thank you so much, sir. It was
Okay.
a wonderful session and very helpful for exam going students, sir.
So don't miss the coming sessions. We have another 6 sessions. Tomorrow breast cancer and brachy instruments. So please don't miss the sessions. It will be very helpful. At least listen and hear. Those people are busy in the clinics. Nothing to worry. And any comments from other people? Any mentors? Any moderators? Any anything? Any modifications?
Sir, just a query, sir. Hello, sir. Can you hear me? Sir, will this is this recording will be available for us, sir?
Yes, yes. Recordings will be available. We will slowly upload in the group. No problem.
Okay, sir. Thank you so much, sir.
Okay.
So I had a query, sir. Now for writing the OSCE, sir, should our answers be point form, sir, or should we write like sentences while answering,
So
sir?
yeah, what I am telling, in every OSCE there will be 4 or 5 questions point wise. Always write. Don't like essay. Point wise, sentence wise. Okay.
Okay, sir. Thank you so much.
Somebody is asked group address, sir. We will get the answers of this session. Mpro group. We will Mpro. We will send the links. No problem. You can WhatsApp me. I am very much thankful for Dr. Ajitesh Avinas. Helped a lot to maintain the OSCE slides and everything. And our Dr. Mentor, moderator today, Dr. Bhattacharya sir, Donna, Priya, and I appreciate all delegates. So hope this will change your life when you will come pass out with your smile. It will be give big smile to me. Thank you very much. So we are ending the session here. If you have any comment, and otherwise we will end the session here. We will upload the in YouTube as well as the Mpro group. Don't worry. Get ready for tomorrow.
So thank you so much, everyone, for joining this session. Clarinet is really glad to have all these people together. So with all your permission, shall I close the session for today?
Madam, please close the session. Please send the recordings.
Yes, sir. Yes, sir.
PM recording you send, and tomorrow also same link will work or another link you will give, madam?
So the coordinator person will brief you regarding that.
Okay. Thank you, ma'am.
Okay.
Thank you for your time.
Yes, sir. Thank you, sir. Bye, sir.